So very warm good evening to each one of you who have joined this final day of the World Preeclampsia series of webinars that has started on May 22nd, inaugurated by the President of Asian Oceanian Society of Radiology, Dr. Evelyn Ho. Ever since May 22nd, we had the state presidents and secretaries of various chapters of IRIA honoring us with being the chief guest of the webinars conducted every day from Monday till today. Today, we have the president and secretary of one of the most vibrant chapters of state chapters of IRIA, the Rajasthan State Chapter. I have the pleasure to invite and welcome Dr. Subhash Taylor, Dr. Subhash Chandra Taylor, who is the president of Rajasthan State Chapter of IRIA, and along with him, the honorary secretary of Rajasthan State Chapter of IRIA, Dr. Jeevraj Singh Rathore. Both of them have been doing phenomenal work in Rajasthan for IRIA and its various activities. Let me invite the president, Dr. Subhash Taylor, to address the audience today. Over to you, Subhash Taylor, sir.
Thank you, Dr. Rijo Matthew, for giving me this opportunity to be here on this wonderful webinar series on World Preeclampsia Week. And as we all know, Dr. Rijo Matthew is a core person, I should say, I don't hesitate to say about. He is a core person in taking forward this program in India. From bottom of my heart, basically, I would like to express thanks, and I put best wishes to Dr. Rijo and his team, definitely Dr. Lalit Sharma and all other members who are taking very pains, and I should say this program is being executed and analyzed, and various theoretical discussion and the various points have been put forward, even as a published in paper, and much of the points are put before the government of India. And definitely it will be very, very important as far as role of radiologist is concerned in preventive radiology and taking care of mother and child. So I really appreciate the entire team of National IRIA Preventive Radiology and Samrakshan Committee in taking care and taking forward all these activities regularly, so nicely, involving all the persons from all over the India and putting forward their experience in a very nice way. So it is my proud privilege to be here on this webinar today. And I really thank again to the Indian Radiological and Imaging Association of Kerala chapter for conducting this World Preeclampsia Week. And definitely Dr. Lalit Sharma is again a very important person and he is also doing very sincere and very hard work since very last years, as we all know. So definitely I must appreciate his efforts also, and the entire team. So thank you very much, Dr. Rijo and Dr. Lalit and Kerala chapter for giving me this opportunity to share my views. And definitely I wish you all good luck for the time to come. And I hope you will definitely carry forward this program very nicely, and we all are very much expectant from you. Thank you, Dr. Rijo. Thank you, Dr. Lalit.
Thank you. Over to you. Thank you. Thank you, Dr. Subhash Chandra Taylor, the president of Rajasthan State Chapter, for the best wishes. And I'm sure Rajasthan will take forward some direction in preventive radiology in a big way in this year as well as in the coming years. Dr. Subhash Chandra Taylor is a radiologist from Bhilwara in Rajasthan, And we have also got the Secretary of Rajasthan State Chapter, Dr. Jivraj Singh Rathore. In fact, my interactions with him came back in 2019 when he organized the first Samrekshan conference in Rajasthan at Jaipur. And ever since that, I've seen him doing a lot of work for IRIA in terms of public interactions, in terms of interactions with the health officials, and also projecting the radiologist as an important person in the healthcare scenario in this country. May I welcome Dr. Jivraj Singh, the Secretary of IRIA Rajasthan, to address this gathering. Over to you, Dr. Jivraj Singh Rathore.
Thank you, Rizzo sir, for inviting me as a guest in this program. And once again, I am thankful to State Chapter of Kerala to organize this program. And Rizzo sir, you are the pioneer of this Samrakshan program as a national coordinator of this program. And I just remember that in December 2019, they invited you as a to launch this program in Rajasthan. And we have a very good initiative taken by you and in our state coordinator, Dr. Renu Sharma, Dr. Gulab. But due to some COVID state, we are unable to continue that program in Rajasthan. Now I just committed to you that we will relaunch this program in next month in presence of you, Dr. Lalit Sharma sir, and because Rajasthan is a very underprivileged state, and as I seen in yesterday paper, we have infant mortality rate of 32. Just increase 1.2, I think 3 points. Better than all over India has taken 2 points. So now we are doing some good things in Rajasthan, but I think after launching of this Samrakshan program in Rajasthan, we will improve this points in sort of IMR. And once again, I am thankful to Lalit Sharma sir and all organizers of this program. लास्ट में सर एक शेर मैं कहना चाहूंगा रिजो सर के लिए कि मैं तो अकेला ही चला था जानी भी मंदी थी लोग आते गए और कारवा बढ़ता गया. Thank you sir.
Thank you.
Thank you sir.
Thank you, Dr. Jivraj, for that wonderful wish and message that you've given. And I'm sure in Rajasthan, Samrakshan will take a giant leap forward with the leaders like Dr. Subhash Taylor and Dr. Jivraj Singh at the helm of affairs. Thank you very much, sirs, for joining us in today's session. Now we will move on to the academic session. This is the final part of our webinar series. Today, till date, we have discussed several aspects of the project Samrakshan. The introduction to Samrakshan, the pathophysiology of preeclampsia, and the importance of early dating scan, then the how the preeclampsia and FGR screening has to be done, and then on which are the vessels, how to do the color Doppler study, and which are the vessels, and how the interpretation is done. And then we discussed yesterday on early onset fetal growth restriction. In today's important aspect of Samrakshan as far as India is concerned, that is the late onset fetal growth restrictions. These are some of the, this is one of the entities that causes stillbirths. These are some of the entities that causes intrapartum complications, birth asphyxias. And one more entity that we have highlighted in our research from India, especially because India has a high incidence of fetal growth restriction, unlike in the West. If West has got only 2 to 3% of fetal growth restriction, our fetal growth restriction ranges from 25 to even 45%. That number itself gives us a wider subsegment to be handled, and because the general presumption by the obstetricians and radiologists and everyone, most of the stakeholders involved in pregnancy and childbirth care is if the fetal weight is more than 10 percentile, the baby is going to be fine. But we have realized in Samrakshan data for the last 2 years that there are 1/4 of babies, 25% of babies over the weight of 10th percentile are having abnormal Dopplers. That category is what we call as the fetal growth restriction in AGA fetuses. That is, it is said that they are appropriate for gestational age, but in fact, they are at risk for developing perinatal hypoxia, and they are at risk for having a stillbirth or even neonatal and perinatal mortality. So this is a point that we want to highlight, and to discuss upon all these two aspects, late onset fetal growth restriction and fetal growth restriction in appropriate for gestational age fetuses, or those fetuses who are more than 10th percentile. This is a new entity that we are trying to promote, and we realize that many parts of the world has reported this thing, unlike in the West. The whole thing that we need to understand is West has got a very low incidence of preeclampsia and fetal growth restriction, and low live births also, low rate of pregnancies also. So most of the data and guidelines coming from the West may not be much relevant, and Indians have to give their data. We have to give our data, and we have to create our own guidelines, because 25% of pregnancies happen here, and 25% of all the indices that you come across, maternal mortality, perinatal mortality, infant mortality, stillbirth rate, they are happening in India. So it is high time for us to give our data, share our data, analyze our data, and come into the guidelines. And we can't expect the West to give us the guidelines for what is happening in India, because they are totally unaware of some of these subsegments, some of these entities. This entity is called FGR in AGA fetuses, something that India has got a high number, and that is what we have to address. To discuss upon all these things, I have with me one of the Samrekshan core team members and one of the course directors of Samrekshan, who was with Samrekshan right from its beginning, Dr. Neelam Jain from Jamshedpur. Dr. Neelam Jain did her MBBS and MD from BJ Medical College, Ahmedabad, and is practicing in Jamshedpur right now. She has been the course director for the first trimester courses and has participated in several CME projects as the course director in Odisha and other places before the COVID era started, and then we went everything online. Let me invite Dr. Neelam Jain to start the academic proceedings. And Dr. Lily Sharma and Dr. Bavaharan also will be joining in the discussion after that. And today's session, I think, will be concluded by the National Academic Lead of Samrekshan, Dr. Bavaharan from Trichy, and Dr. National Joint Coordinator for Samrekshan, Dr. Lily Sharma from Guna, who is doing a phenomenal work in Samrekshan. Over to you, Neelam.
Thank you so much, sir. Good evening, everyone. I am glad to be a part of this initiative, which is addressing such a huge problem, which is leading to and contributing to a big proportion of perinatal morbidity and mortality in India, which is FGR. And today I am going to be discussing what constitutes the major chunk of this FGR. Is FGR restricted to the babies we see on ultrasound at 20 weeks, which are visibly small, whose uterine artery Dopplers are abnormal, whose ductus venosus are abnormal? No, they actually constitute only 30% of the cases of FGR, and the majority of the cases of fetal growth restriction come from the subset that we are going to discuss today, which is the late onset category of fetal growth restriction. So let us try to understand how these two entities differ when we are looking at both of them in comparative terms. Early onset FGR is very easy to spot. It is right there. You look at the scan, you look at the biometrics, you try doing the Doppler, and right there you will know that there is a fetus which is visibly growth restricted. The Doppler parameters are very clearly indicating that there is growth retardation, there are hemodynamic alterations, and you will probably have no difficulty picking up an early onset growth restricted fetus. But is a late onset FGR equally easy to pick? No, it is going to hide, it is going to masquerade as normal, and you have to be looking keenly into your case, being very, very Doppler conscious, being very, very graph conscious, and then you are going to pick up this category of fetal growth restriction, which is the late onset FGR. Now, we are going to revise a few terms which we have been doing for the past 1 week, but it is very important for all of us to get this inside our system as to what constitutes an FGR. FGR, or fetal growth restriction, by definition, is failure of the fetus to reach the endorsed growth potential at term. What it means is that if a fetus had the potential to reach up to 3.75 kgs, if the fetus does not reach there and stops at say 3 kg, that fetus is a growth restricted fetus, as much as a fetus which is less than 2.5 kilograms. So these definitions and the description was very beautifully described by the Barcelona guidelines. Graticos et al. They just kept on talking about, they published a number of papers on fetal growth restriction, and we must all be very, very well versed with these papers, with the findings, with the Delphi consensus, because that is going to help us in our scans. So FGR, again reiterating the same thing, is a condition in which a fetus is unable to achieve its genetically determined size. And why doesn't it reach its genetically determined size? Because there is some form of obscure placental insufficiency. So the traditional definition for all of us about fetal growth restriction was any fetus who was less than 10 centile was growth restricted. So if we look at the birth weight of all the babies who are born at a certain time, we will find that, of course, there is most of the babies are born around the median weight. And there is this category of babies who are a little less than others. There are some which are definitely less in weight than the others, and there is this category which are a little more in weight than the others. So that bell curve actually represents a normal distribution of fetal weight in the population. Initially, it was thought that we should be focusing probably only on the category which is definitely less than the others. That is, say you're looking at all the fetuses who are less than 10th centile of birth weight. But gradually we realize that it is not just this subset which is contributing to a lot of perinatal morbidity and mortality, but a larger subset than that. So you're probably wanting to look at all the fetuses who have growth percentiles less than 50. So we were talking about a bell curve, but when we are doing a scan, how do we know where our fetus is standing? And the answer is very, very simple. You have to plot the fetal weight on a growth chart. These growth charts are available in your machine, and if you're longitudinally following up a fetus, you will have multiple dots, and you can see how the growth velocity is going, where at one point, at what percentile is the baby at. And that percentile will guide you whether your baby is above the 50th centile, whether the baby is below 50th centile. And of course, when you look at repeated scans and you see the centiles are falling, then you become a little more cautious and you start looking at the fetus in even greater detail. So what does the data on stillbirth in India say? So if we can broadly divide the stillbirths in India into preterm babies and term babies. So when we talk about preterm babies, most of the preterm stillbirths are small for gestational age. So if a fetus was supposed to be 27 weeks, and if you have a stillborn, mostly the weight is going to be lesser than that of a fetus, lesser than the weight expected at 26 weeks. So they are going to be SGA for that gestation. But when you look at all the stillbirths which happen at term or near term, you find that most of the term stillbirths are not truly small for gestational age, and that is where the biggest question mark in FGR lies. So what we understand now is that fetal smallness is no longer the only criterion to diagnose fetal growth restriction. Smallness definitely is a predominant feature in early onset FGR, but in late onset FGR, it might not be a factor. Might be, might not be. So why does late onset fetal growth restriction behave differently than early onset fetal growth restriction? In early onset fetal growth restriction, the placental damage is profound. It is obvious, and that leads to abnormalities, and that leads to poor placental and maternal and feto-maternal exchange, and that causes all the trouble. In late onset fetal growth restriction, the placental damage is less. It is of the order of less than 30%. What happens is that in the initial stages, when the fetus is not really putting on that much weight in absolute terms in the earlier part of the gestation, since the placental damage is less, placenta is providing enough to maintain growth. But once the baby progresses and starts putting on weight rapidly in the later part of the gestation, the placental insufficiency starts manifesting, and now growth restriction starts to show. So the new approach is that you must definitely investigate all the fetuses who have estimated fetal weight less than 10 centile. But you must not ignore and you must not miss to evaluate all the fetuses who lie between 10th to 50th centile as well, because a huge chunk of late onset FGR is going to come from this subset. Also, do not just look at the weight of the baby, you have to look at your Dopplers carefully. This has been discussed enough number of times, but we are going to go through this again and again to imprint it properly in our minds why we are supposed to look at the Dopplers nicely. So the question is, which vessel do you want to look for and when? So when you talk about the uteroplacental circulation, which is the representative of the uteroplacental circulation, it is the uterine artery. So uterine artery reflects the status of uteroplacental circulation, and in a non-gravid uterus, the resistance of the uterine artery is very high, but as there is a pregnancy and the gravid uterus, now the trophoblastic invasion occurs and the arteries transform. With advancing gestation, the resistance keeps on decreasing and the diastolic flow keeps on increasing. So the uterine artery is the maternal compartment of feto-maternal exchange. In a non-gravid uterus, as I said, the uterine artery shows very high resistance and it has low diastolic flow. But when pregnancy occurs, then from the first trimester itself, you see that the diastolic flow starts to increase, goes on increasing in the second trimester, and the diastolic flow becomes even greater in the third trimester. So the diastolic flow just keeps on rising, and these changes and this pattern we have to understand and always look for. So the uterine artery initially around 2010, 2011, it was thought that the main use of uterine artery is only in the first trimester, and probably in the second, third trimesters, uterine artery is not really contributing to any good information about fetal growth. But the idea was challenged with a lot of research, and now it is clearly established that if a fetus is growth restricted and has an abnormal uterine artery PI value, then in this particular fetus, there is going to be an increased risk of abnormal cerebral Doppler at term. It also means that there is a chance that there could be a poor perinatal outcome. And of course, if the uterine artery the resistance has been high, then it is also associated with an increased risk of hypertensive disorders of pregnancy like preeclampsia. We've spoken about the uteroplacental circulation. Now we'll talk about the fetoplacental circulation. And which is the representative of the fetoplacental circulation for us? It is the umbilical artery. Umbilical artery represents the fetal compartment of the feto-maternal exchange. There is another vessel which is representative of this part of the circulation, and we are going to talk about it today. But let's just talk about what is commonly known, and the most commonly known representative of the feto-placental side of the feto-maternal exchange is the umbilical artery. So that represents the fetal compartment of feto-maternal exchange. It is a very crucial vessel for diagnosing and prognosticating early onset FGR. How it works is that it is directly, the function and the resistance of the uterine artery is directly related to the kind of placental damage. So approximately when there is 30% of placental damage, the resistance in the umbilical artery reduces. And once the degree of placental damage increases and goes to the order of, say, 60%, we know that the diastolic flow becomes absent. And once the placental damage exceeds 70%, then there is reversed end diastolic flow. But all of this is not really going to happen in late onset FGR. Why? The placenta is all happy because the placental damage is very less. It is less than 30%. So there is good amount of placental tissue available for the uterine artery to push blood, and therefore the umbilical artery is not really showing us a lot of resistance. So umbilical artery Dopplers are generally normal in cases of late onset fetal growth restriction. So this is an example of umbilical artery Doppler in a proven late onset FGR in third trimester, and it looks all happy. We look at this and we say, oh, the umbilical artery is fine. And if we just rely on this parameter to diagnose fetal growth restriction, we are definitely going to miss a lot of things. So umbilical artery Doppler in late onset FGR is normal in almost all cases. And why is it normal? Because it does not reflect mild placental disease. So does that mean that mean umbilical artery Doppler is of no use in FGR? No. The mean umbilical artery Doppler, the umbilical artery Doppler needs to be plotted on charts, and you have to look at how it is behaving, because the placental insufficiency starts to manifest. So the PI can be seen as a rising trend, and that could just alert you about possibility of a late onset FGR happening. And of course, say you're talking about a late onset FGR around 32-33 weeks, then it is probably an overlap between the early and late onset FGRs. So there are instances when where the cardiac dysfunction will also manifest, and that will also start playing a role. So of course, once you see the umbilical artery and you do the spectral, you get the spectral waveform, you plot the PI on charts, and you can assess the trend of the umbilical artery PI. But having talked about all this, what is the star performer in late onset FGR? It is nothing but the MCA, and MCA is what is going to give you the greatest and the best indication about possibility of growth restriction happening. So normal MCA Doppler basically reflects brain oxygen, normal brain oxygenation, and it basically has high resistance flow. Normal MCA has high resistance flow, and the diastolic flow is less. So we have to know what is normal to understand what is abnormal. So in normal MCA, the resistance is high, the diastolic flow is less. This is how it looks like in a normal fetus. But when the fetus starts becoming growth restricted in later stages, that is in late onset fetal growth restriction, the cerebral changes generally are the first ones to appear. So MCA now in late onset FGR is reflecting fetal hypoxemia, and that causes decreased resistance in MCA. So once there is the baby is hypoxemic, it tries to save crucial organs. The crucial organs are the brain, the heart, and the adrenals. And brain, how does it save it? By reducing resistance to blood flow. So the resistance in MCA decreases, the vessel dilates and the diastolic flow increases. So this is what happens in MCA to the diastolic flow. The diastolic flow increases in late onset FGR. So if you have an MCA abnormality in late onset FGR, you know that you are probably looking at FGR for sure, because it is highly specific. It represents fetal brain sparing. And if you observe a steep decreasing trend on the MCA chart, then it is a red flag. In later gestations, the PI in MCA generally falls, but of course, if the extent or the fall is really steep, then it is telling you that you're probably looking at a late onset FGR. So the general trend, as I said, of PI is that it is going to fall in the later half of the gestation, but if it falls really steeply, then you're looking at FGR. So we've spoken about umbilical artery and we've spoken about MCA. Are these the parameters we are going to rely on for late onset FGR? The answer is no. There is something which is even more sensitive and is going to give us an earlier clue that probably this fetus is going to be growth restricted, and that is nothing but the cerebro-placental ratio. Now, cerebro-placental ratio is nothing but a ratio of PI of the middle cerebral artery and PI of the umbilical artery. It is more sensitive than just the MCA Doppler, and CPR abnormality will precede MCA abnormalities in most of the cases. So the MCA looks good, the umbilical artery standalone looks fine, but when you look at the ratio is altered, and this could be the first clue that you have towards your FGR fetus. So CPR in late onset fetal growth restriction predicts fetal hypoxia. Of course, if you're looking at the CPR, you have to look at the nomogram, and you have to know that at what gestation, what is the normalcy of CPR, and at any gestation, if the CPR is less than 5th percentile, then it is critical, and it is marker of hypoxemia in fetus and not acidemia. So it is basically a little, CPR gets altered a little before the MCA gets altered. But there is a new vessel and there's a new kid on the block, which is the umbilical vein Doppler. So there was this study in 2019 which spoke about the umbilical vein Doppler, which can be used to pick up FGR earliest than all other parameters. So, but then when we talk about umbilical vein Doppler, we need to understand that it is very poorly studied. It is very difficult to replicate. They talk about measuring the umbilical vein blood flow normalized to the abdominal circumference of the baby. So the calculations are a little complex. They have to be automated, because if you make a little mistake in calculating the vessel area, you are going to be miscalculating or making huge mistakes in calculating the umbilical vein blood flow, and the moment your umbilical blood flow measurements go wrong, your entire calculation is going to go for a toss. So the umbilical vein Doppler, of course, needs a little more research. People are working on it. It is said that it is a better reflector of placental function than umbilical artery. And umbilical vein flow might already be reduced in first or second trimester in late onset FGR, even before the clinical diagnosis of FGR can be made. So umbilical vein is a promising marker which people are looking at, which people are researching to know whether it has a good, reproducible, usable role to play in FGR. But as of now, we are not really using it for our routine scans. But of course, all of us can start looking at the umbilical vein flow in our cases and at least start establishing what is normal. So it is, there are talks and there are researches about a certain pulsatility in the umbilical vein that can also predict an adverse event in FGR fetuses. So this needs to be studied further. This needs a little more research. But again, we have to remember that this vein also is going to play an important role in future in FGR fetuses. Apart from the vessels, what is the other thing which can give us a good clue about fetal growth restriction? Another thing which can give us a good clue about FGR is the growth rate. So what is the growth rate and why are we talking about the growth rate? We're talking about the growth rate because Delphi consensus spoke about the growth rate and gave us a few definitions. And it said that at least 2 out of these 3 criteria will categorize as late onset FGR. And what are these 3 criteria? Either the AC or the estimated fetal weight is less than 10 centile, or the growth falls by 2 quartiles. So the absolute measure of the AC and the estimated fetal weight need not be less than 10 centile. Maybe it is 20 centile, but previously if it was 80 centile and now it is 20 centile, then it has fallen by 2 quartiles. Then you are looking at a falling growth rate, and that can also tell you about late onset FGR. And the other criterion which is there is the CPR, which is if the CPR is less than 5th centile and if the umbilical artery PI is more than 95th centile, or the uterine artery PI which is more than 95th centile, then you say this is late onset FGR. So this is an example of what it will look like on a chart. If you plot your growths on the growth chart at 2 different points in time, and you observe that the growth was say at 70 centile and now is at 10 centile, is at say 11 centile or 12 centile, then by absolute criterion probably this is not an FGR. But because the growth has fallen by more than 50th centile, then you say that yes, the growth velocity has suddenly dipped, and now you know that this fetus is growth restricted. So we need to understand that the placental damage is mild in FGR. So many a times the fetus will not begin to growth restrict till as late as 35 to 36 weeks. What is the important thing to understand here? We need to understand that if you screen the baby's growth only once between 32 to 40 weeks, most of the obstetricians they refer patients only once in the 3rd trimester. So if you're only doing a growth scan once in the 3rd trimester, you really do not know that the growth velocity is falling or your centiles are behaving funny, and it is highly likely that you will miss a large proportion of late onset FGR. So what is the definition of late onset FGR? The Delphi procedure, there is an absolute criterion which says if the AC or the fetal weight is less than 3rd centile after 32 weeks, then you say this is late onset FGR. Or if you have at least 2 out of these 3 criteria, the AC or estimated fetal weight less than 10 centile, or AC or estimated fetal weight crossing 2 quartiles on growth chart, or CPR less than 5th centile and umbilical artery PI more than 95th centile, then this constitutes late onset FGR. So what are we trying to understand from all this? We are saying that small for gestational age is not always FGR, but small for gestational age less than 3rd centile is always FGR. So babies which are less than 10 centile but more than 3rd centile need additional parameters for us to qualify the baby into the FGR category. So estimated fetal weight more than 10 centile, again by definition is not SGA, it's not a small baby, but it might be FGR. So late onset FGR constitutes 2 categories. There is small for gestational age babies and there are appropriate for gestational age babies. So the small for gestational age babies, either their Dopplers are normal and they are less than 3rd centile, or they are less than 10 centile and they have Doppler abnormalities. Appropriate for gestational age babies will not be traditionally SGA. They will be more than 10 centile in their estimated fetal weight, but they might have Doppler abnormalities, although they may show falling growth velocity. So if your fetus by the Barcelona staging is stage 1, if it which is basically severe smallness, that is AC less than third centile, and is showing mild placental insufficiency. So the criteria for saying that you're dealing with a stage 1 FGR in late onset FGR is that your fetal weight is less than third centile, your CPR is less than fifth centile, a combination of these, an umbilical artery PI more than 95th centile, the MCA PI less than fifth centile, and the uterine artery PI more than 95th centile. So what do you do when you find a stage 1 FGR? You monitor weekly, and as soon as the baby is 37 weeks, you deliver. In stage 2, there is the placental insufficiency is getting a little more severe, and now you might have umbilical artery changes in this fetus as well. And when that happens, you have to monitor the fetus bi-weekly and deliver at 34 weeks. Stage 3 and stage 4 do not really apply to this. So what is the conclusion from our talk? The conclusion is that late onset FGR is like the biggest imposter in growth restriction. You might not be able to pick it up if you do not look into your scans with a keen eye. You cannot rely only on symphysiofundal height for assessing growth. So those days are gone where you just look at the symphysiofundal height, and then if it is not really corresponding, you send the patient for a scan. The norm has to change. There have to be more scans in the third trimester if we are wanting to pick up our late onset growth restricted fetuses. So we have to get used to look at our growth charts carefully. We have to include Dopplers in all our third trimester scans. We have to do at least 2 scans in late third trimester if we want to pick up late onset FGRs or term FGRs. So there is this case which I've done today, and maybe I can discuss it, and maybe Dr. Lalit and Dr. Babaharan can contribute to what is happening in this case. This was a case, I have done her first trimester screening, second trimester screening, and 2 third trimester screening. This is a 26-year-old female. BP was normal when she came in first trimester, and we did her artery Doppler sample. And what we found was that the mean PI was a little high. We advised the patient to, basically in private practice, you do not advise the patient to, you advise the physician to kindly look into the uterine artery Doppler and advise, her probably, and give her a prophylaxis of 150 milligrams of aspirin at night time. As expected, was not really followed. In second trimester, the patient, when the patient came, there was the Doppler findings looked like this, and they were a little confusing for me because the right-sided uterine artery looked fairly good. The left uterine artery did show a little resistance. The mean PI was around 90th centile, and we were not really certain about what we are dealing with. The patient came to me after the anomaly scan at 35, and at 35 weeks, when I did the biometry and I looked at the growth, I saw that the AC had on the chart, I was seeing that the velocity, the growth velocity was definitely less, and all the parameters were falling towards the fifth. At 35 weeks, I looked at the MCA. The PI was quite reassuring. It was 1.3. I looked at the umbilical artery. The diastolic flow did not look great, but was still okay. But what was giving me a very good hint about a possible abnormality in this case was, you look at the PI of MCA. The PI of MCA here is 1.3. And the PI of umbilical artery is 1.23. So the CPR at this point in gestation was barely about. And according to the Barcelona calculator, when I used it, I figured out that this was pathological and we were dealing with an abnormal CPR. I went back to look at it. uterine artery. And as expected, the uterine artery was still showing high resistance, and the uterine artery PI was above 99 centimeters. Today I scanned the patient, and this was the fourth scan of the patient with me. And what I'm seeing here in the MCA was, now the PI has definitely fallen. So the first time at 35 weeks when we scanned the baby, the MCA PI was normal. It was only the CPR which was abnormal. Now the MCA PI is visibly, absolutely, clearly low. There's increased amount of diastolic flow in the MCA. When I looked at the umbilical artery flow, again, it is the diastolic flow looks pretty less for a 37-weeker. And of course, when you look at the PI of the umbilical and the MCA, you know that the PI of MCA is 0.88, the PI of umbilical artery is 1.17, and the CPR is definitely altered in this case. Again, we looked at the uterine arteries, and the uterine arteries show high resistance today. And when we were looking at the growth of the baby, when we were looking at the chart, if you look from 35 weeks to 37 weeks, the baby has effectively not had any growth. So this baby at 20 weeks, at the time of anomaly scan, looked normal. The growth parameters were corresponding to gestational age. And when we scanned her at 55, we picked up an abnormalcy. It gave us a hint that, and the growth parameters were less, and gave us a hint that probably we're dealing with a late onset restricted fetus. But when we scanned her second time in the third trimester, we realized that the baby is severely growth restricted. It is not growing it. And today, the advice gynecologist was given that baby has now crossed 37 weeks, and probably it is high time that you get the baby for an untoward event. So this is how late onset FGR can behave if you're not really scanning your third trimester scans. If you're not doing them nicely, if you're not really integrating doctors in them, there is a good chance you are going to miss a big proportion of late onset FGR. So the message from here is that please do not do your growth scans without doctors. Doctors are an integral part. An integral part of the screening protocol for FGR. It is the MCA Doppler which gives us good information, but the earliest clue can be obtained if you look at cerebral placental ratio and look at it carefully. And of course, you have to plot the chart. You can't just rely on absolute criteria. Like in the example that I just gave, the CPR was just above 1. So you cannot rely on criteria like the CPR should be less than 1, should be more than 1. Everything you have to plot it on charts, look at the normograms for the particular situation and what is normal and what is not. Thank you for your patience. And thank you for giving me this opportunity to be here.
Thank you, Dr. Neelam. That was a very good insight on detailed insight on the late onset FGRs. Okay. See, late onset FGRs are really very difficult to pick up once. One is for the reference point of view. How often do you want the clinician to refer to you? For example, you've done a scan at 28 to 30 weeks and everything looks absolutely normal. Unless otherwise we do the next scan, probably in 2 to 4 weeks or 5 weeks, we'll not be able to see whether the growth has fallen by 4 quadrant or the CPR is becoming normal. So on what basis you call back the patient, or what do you recommend for the radiologist, for the gynecologist, for you to refer the patients? Is it necessary that we put one more scan in the obstetric scanning pyramid?
I think it is absolutely necessary because the term FGRs, especially the late onset FGRs which develop later after say 36 weeks, they are going to be completely missed if you do not have scans, at least 2 scans in the third trimester.
What is your recommendation? For example, at what time you want to do the scan for those patients? For all the patients, or do you want to do a selected list of patients?
I would want to scan all the patients twice, at least 2 times in the 3rd trimester. Say one scan around 34 weeks and the other around 38 weeks.
So what is the statistics, I mean, logic behind doing a scan at 37, 38 weeks? If at all you're going to plan to deliver, if you're
we are not really planning to see. There is going to be a subset which is not going to be caught at 34 weeks.
Yes, agreed.
So unless and until you are and this baby probably considering it as a normal baby and not really considering this as a FGR baby, the clinician is probably going to try to continue the pregnancy till term. And if you do not intervene with a scan earlier than that, say around 37, 38 weeks, then you are not really going to be picking a growth velocity lag.
Okay. So let's finish off these questions before getting into. If at 34 weeks CPR ratio is less than 5, 5th centile, rest other parameters are normal. Next, what do you do?
If the CPR
Question by Dr. Renu.
So if the CPR is less than 5, then I would want to follow the fetus weekly.
Okay, so you're putting it into 2. Okay.
So this could be, see, we are not really talking about only babies who are SGA. This could be an AGA. So AGA is also an entity which needs to be clearly understood. So there will be a subset of fetuses whose growth is going to be normal, but who will have hemodynamic changes in the form of alteration of CPR, and they also need to be followed up closely.
Okay. See, there's one more question from Dr. Madhu Bhavana. Only CPR less than 5th centile in an AGA fetus with other Doppler parameters are normal at 37 weeks.
You deliver.
You deliver?
Yes, you would deliver.
To everybody listening, see, there is a simple concept that you need to understand here. We are measuring a CPR, which is a cerebro-placental ratio. Why this CPR becomes important is a question. Why don't we measure? See, initially 4 years, 5 years ago, we were making decisions based on umbilical artery. We were not including the MCA into the decision making. Why this decision making was brought in by Dr. Gauss and a lot of other people is very simple. Because the umbilical artery represents the placenta. It gives only the damage what the placenta has undergone. Whereas the brain of the fetus gives how the fetus responded to that insult. See, already there is a hypoxia. So how the fetus has responded to this particular placental damage is important. Why you don't see umbilical artery abnormality in late onset FGR is, for an umbilical artery to become abnormal, you need at least 50% of the placenta to be damaged. Then only you pick up an umbilical artery abnormality, then you do a sequence, umbilical artery, then I do the MCA, then I do the aorta, then I do the ductus venosus. All these are in sequence. But in late onset FGR, what happens? There is only placental damage which is less than 30%, which is sensed only by the fetus and not by our Doppler. So it is sensed by Doppler, like the fetus picks up, say the MCA velocity changes, the MCA parameters completely change for the fetus. That is why we always measure CPR, which is nothing but the fetus response, which is the cerebral, to the placenta, which is the placental damage. How the fetus has responded to the fetus damage, placental damage. This is what we take into consideration. That is why CPR is measured rather than a single parameter of umbilical artery or a MCA. Even if you take a MCA just like that and do a valuation, if you put it in charts and everything, it might be abnormal. But when you actually combine with the placenta, the placental thing, which is the umbilical artery, then it gives you the exact value of this CPR. That's why it is important.
And plus, once the baby is 37 weeks, it is mature enough to survive outside, and the outcomes are better if the baby is outside. Interventions cannot be done if the baby is inside beyond, you have a very good reason to get the baby out if the CPR is altered. and the baby has attained maturity. That is what the protocol clearly states.
We don't expect the baby also to grow by, let's say, weekly 200 grams after an insult that has happened. You don't expect the baby to grow by 200 grams or 100 grams a week. So the baby is not going to gain much weight, rather than we are going to inflict more damage to the baby after
Yeah.
and that is why we are
And the
planning to
stillbirth
deliver.
rate also increases. Stillbirth
Yes.
rate.
Stillbirth rate
And
increases.
yes, and there are the chances
So that's
of
why we are creating more damage to the
yes.
Yeah, brain
And
also.
no advantage, and there is the if even the live baby is born, it is going to have a cerebral palsy like disorders. So we have to
Even if
think
it does
about
not
it.
develop a frank cerebral palsy, it will have
Yes, developmental
changes
delays and
consequent to
this.
hypoxemia, and that
Ah.
is not really good for the baby. So
Yes.
you should not really be subjecting baby to hypoxemia if you know that it exists, and you have the option of getting the baby out because the baby is mature.
So to
Yes.
concise, there is a hypoxemia which is certain. You don't expect the baby to grow much after 37 weeks. Number two, you prevent the baby from getting into neurological damage, and also you prevent the stillbirth and postnatal morbidity and mortality.
Yes.
So these are the reasons why we want to deliver the fetus at 37 weeks after the baby is mature. So if the baby is less than 37 weeks, yes, of course, you're going to give steroids for the lung maturity and deliver. But if it's going to be more than 36, you can deliver it in an emergency if it's required also, without any steroid being given in these patients. That is the point. A question by Dr. Jitendra Bansal. Mostly we get patient at 34 weeks with only abnormal MCA, normal weight.
You follow it weekly.
Yeah, so that the question is answered already. See, you don't take only MCA. When you do a Doppler, it should always, after 32 weeks, it should always be CPR. Let's keep it that way. It is CPR. That is, you measure the middle cerebral artery and you measure the umbilical artery. Again, umbilical artery represents placenta. Again, I'm repeating, umbilical artery represents the placenta, whereas middle cerebral artery represents the fetal response. So you actually take a ratio of this to make sure that the baby is doing fine or the baby is struggling. That is why the CPR of less than 5/5 percentile comes into play. Okay. So, Dr. Neelam, you showed your last case. In that, actually, there was a uterine artery which, from a high resistance, came to almost the resistance decreased.
Yes.
Do you expect abnormal uterine artery in case of late onset FGR? We have talked about the umbilical artery. Do you expect?
Yes. In fact, late onset FGR, whenever there is a uterine artery abnormality, in cases of late onset FGR, the outcomes are going to be a little more dismal than usual, and there are a number of cases where the uterine artery abnormality manifests in the third trimester and does not really show up in the second trimester.
So see, the uterine artery, again, it also represents the placenta, uteroplacental circulation. So it also gives you a fair idea of about how the circulation is and how the vessels are. One anonymous, instead of mean PI of uterine artery is abnormal, even PI of single uterine artery abnormal at 11 to 14 weeks, is it significant to go for FGR?
You always have to consider the mean uterine artery PI, and you cannot rely on a single. In cases of lateral placentation, you can have abnormal PI on one side and a fairly good PI on the other side. So,
so I think after 4 days, 4 or 5 days of this continuous talks, every one of us should understand if it is uterine artery PI, that is, if you want a PI, it's always a mean PI. Mean PI is where you add right and left and divided by 2. That's the mean PI. So that is what you have to take. There is no single uterine artery business here. Number one. Number two, no notching is considered because the notch is included in the PI. So you need not mention about the notch anymore.
And it is commonly seen in the 45% of the cases, normally also notching.
Yeah. You need not take that into consideration.
Baba Haran, so what is your experience with term FGR? I mean, what is your take on term FGR? We do have cases where mostly these cases are AGA. And
I think it was very well dealt with by you. I mean, if there is going to be a late, if everything is AGA and suddenly the patient lands to you for a scan at about, let's say, 35, 36 weeks, and suddenly you pick up a CPR abnormality in those cases. See, again, I want to stress one point. There was a question by one of the attendees today. Do you do a Doppler or a routine USG at 34 weeks? Now, let's be very clear. After 28 weeks, Doppler is routine. There is no routine
yes.
USG and Doppler. The Doppler becomes a routine in all cases after 28 weeks.
And
You
even in the
cannot,
early trimester, I think, even
yeah.
in all the trimester, without
We
Doppler,
must
First
integrate.
trimester, in the first trimester, uterine artery and ductus venosus is a must. In the second trimester, if, for example, the first trimester uterine artery is normal, everything is fine. Even if you miss the uterine artery in the second trimester, it's fine. But if you start doing it, you will start enjoying Doppler. I mean, you'll learn more about it. And in third trimester, it is a must that you do a Doppler. It is like when you have a cerebral mass on MRI, you always give a contrast. You don't ask somebody else to do a contrast whether to do or not. You always give a contrast for complete analysis. Now, coming back to the question, Doppler is essential in all the cases, number one. Number two, suddenly when I pick up a late onset FGR, if it is after 36 weeks, the first thing is to deliver. That's for all the obvious reasons that we have told. If it's more than 36, I generally tell them wait and deliver the baby because there is a abnormality. And I don't actually rely on one particular. Suppose a patient comes to me at 36 weeks only, the first time. Let's say I'm seeing a patient seen by some other person and suddenly comes to me. I evaluate. If I see a CPR abnormality, generally ask the patient to wait and again call back the patient, repeat the CPR. And if the CPR is there also abnormal, I tell them this is an abnormal baby, deliver. The most common cause of CPR being less in our practice is giving compression, over compression on the probe. Do not give, technically, you don't give too much compression on the head of the fetus. If you give too much compression on the head of the fetus, the resistance increases. So make sure whenever you put a Doppler in the MCA, suddenly you don't see a diastolic flow. Don't commit it as abnormal. See how much pressure you have given, release the pressure, allow it to settle for some time. Again, redo the Doppler by giving a very, very little pressure on the abdomen of the maternal abdomen. Then you will see the diastolic flow appearing. So one of the most common causes of problem that we all face is giving too much compression with the probe on the fetal head. Don't do that. Always reduce the pressure and repeat the Doppler again to analyze that. Intermittent abnormal CPR, which comes normal on review after some time. Yeah, that's what I was saying. So you would have done a wrong technique. Your technique is wrong. It's not a big deal actually to have a wrong technique. It's easily correctable. Like you just have to avoid too much pressure on the maternal abdomen with your probe. Don't do it with anger, you do it with love. What to do if fetus comes at 14 weeks and does not fit into the time criteria of FMF software? Yeah. See, after 14 weeks, if the patient comes, your Doppler is still valid. Let's take into consideration because the secondary, the spiralizations, all the placental invasions, placental development happens till about 16 to 17 weeks. So if you can have an abnormality of the uterine artery still 16 weeks, and if you're able to start aspirin before 16 weeks also, it is better for the patient for a good outcome. Whereas your CRL, if it is more than 84, you cannot do your NT. Remember that. So we repeat always in abnormal CPR. Yeah. See, that's what Dr. Sheila Jain, you have to repeat in all cases just to make sure you gain the confidence. See, initially when you do it, you just can't allow a 32 weeker, suppose a 33 weeker comes in, you just put in one but single value, you send them, okay, deliver the baby. And the obstetrician will call and ask you, everything is fine, why did you ask to deliver the baby? They might ask for the second opinion and all those stuffs. But whenever you have it, it's not harmful to repeat a scan after about a gap of 5 minutes or 10 minutes and then give your final verdict on that. How to calculate if risk is high or low? Raki Agarwal from.
By
Yeah,
the
Neelam.
weekly chart we can have.
The risk, you might not
No.
really get the risk, but of course your uterine artery is definitely going to guide you. So till the growth comes, first, because there are windows that are, unfortunately, that we have only windows wherein we can answer questions like the risk at this time. And if we do not have a software for certain gestation, then probably we can just probably rely on what we have with us and guide the patient accordingly and recall the patient again at another trimester. And then in the second trimester, calculator, you can get the risk.
You can keep simply remembering one particular. I see in the first trimester, a mean uterine artery PI cannot be more than 2.5. The second trimester, it cannot be more than 1.75, 0.75 less. In the third trimester, it cannot be more than 1 mean PI. Uterine artery. See, that's simple way of remembering. It's not actually the exact values I'm talking about. I'm just starting an arbitrary value. 2.5 in the first trimester, 1.75 in the second trimester, and 1 in the third trimester. It's easy to remember over 1. So keep things simple always.
So there's one question which says, is the DV-PI cutoff value in first trimester 1?
Is 1, is it? See,
for me, I do not remember values. I never remember values. I only look at charts, and I think that is how it has to be. You have to look at the nomograms. For a certain gestation, we cannot go on remembering numbers. It's not practical.
In the first trimester, just consider one thing. Where is the A wave? Is the A wave above the baseline or below the baseline? If it's going to be below the baseline, you call it reversal of A wave. If it is above, it is normal. Just keep it that much in the first trimester. That's enough. In the third trimester, you come to your PI. Don't confuse too much, because in the first trimester, even if you say the PI of DV is high, it is not pointing anywhere or it's not going anywhere. So in the first trimester, see where the A wave is. Okay, so that is the important. Is the A wave above it or below? Then similarly, in the if it is above, it is normal. If it is below, it is reversal. Just keep that in the first trimester. That's enough.
And we have to stop getting used to understand, trying to memorize numbers as in absolute terms. We have to start looking at everything as a continuum, and we have to stop learning to memorize those values.
So it is not necessary, actually, as Dr. Neelam says, it's not necessary to actually memorize numbers. You can keep simple values. Say, for example, uterine artery, just when you do the mean PI, if you have the mean PI in the first time is 3, it is abnormal. Put it in the chart and find it, whether it is abnormal, how abnormal, what is the recommendation comes. It's as simple as that. It's just for you to have that confidence. Okay, I know this number, it gives you more. Don't go with the value blindly. Logically, umbilical vein Doppler will be promising since it directly represents the efficiency of placenta to feed the fetus.
The trouble with umbilical vein, from what I could gather, was that the assessment is very tricky. It is very complicated, and wherever people have researched to it, they have used automation, semi-automation, to get values of the umbilical blood flow. And now, since if you are going to be doing it manually, you are going to have errors, and if you do not have absolute values, then of course you can be talking in terms. So definitely it is under research, and it needs to be properly understood as to how to do it. The methodology itself has to be understood.
Yeah, two problems with umbilical vein, as far as what we have done. We have done a lot of cases on that. So there's two problems. One is umbilical vein is nothing but the amount of blood filtered from the placenta. Umbilical vein takes the blood which is filtered from the placenta, right? So here the placenta is the oxygenating membrane. But what happens when the umbilical artery is trying to push blood? The placenta do not have space to filter the blood and send it across to the umbilical vein. Another important thing we have to consider in umbilical vein is that the umbilical vein diameter depends upon the flow. If the flow in the umbilical vein is less, or the blood volume is less, the umbilical vein diameter is also going to be less. It's like something like your IVC, right? It's something like your IVC, where in dehydrated state, you don't get good distension of IVC. Whereas in well hydrated, highly volume overload state, you get the IVC distended more. The umbilical vein is similar to that. So the umbilical vein has always to be calculated. The umbilical flow has always to be calculated pertaining to the area of the umbilical vein, not about the amount of velocity. You cannot pick up the velocity. The diameter is wide, the velocity is low. The diameter is small, the velocity is high in the umbilical vein. So it's very difficult for us to, because again, the amount of blood flowing to the umbilical vein, because umbilical vein is going to take blood, oxygenated blood to the fetus, all agreed. But from where does it start? It starts from the placenta. If the placenta is not able to give enough filtered oxygenated blood, from where will the umbilical vein get the blood from? Number one. Number two, the diameter depends upon the blood flow through the umbilical vein. So it's always to be calculated according to the diameter or the entire area of the umbilical vein to the amount of blood flow. It's like if you are doing the AV fistula for renal failure patients, you calculate the amount of blood flow through the fistula site. It is similar to that which you have to calculate in those cases. So umbilical vein, yes, it represents the fetus, but I don't think so. Unless and otherwise, if we have a software to calculate the entire umbilical vein volume or the area, it's very difficult for us to give a good insight on umbilical vein. Let's wait for the research to outline. Lalit sir, you want to add anything, sir?
No. I don't have any experience on the umbilical vein.
We have to take a lot of inspiration from Lalit sir. Like he has actually made this sort of a movement wherein he is targeting FGR aggressively. He is trying to pick them up. So all the fetal radiologists actually have this responsibility on them to become a little more growth conscious and Doppler, and we have to start integrating Dopplers in our routine practice. We have to know the vessels that we need to sample in the first trimester, the second trimester, and the third trimester to pick up our FGRs. And if all of us start doing that, maybe the overall we can probably make a difference, and we can actually contribute to the real sense.
Yes, I am getting because I am doing it. So you have rightly said that we have to start doing the Doppler. Without doing the Doppler, you cannot imagine to identify the FGR patient, and you cannot able to reduce the perinatal and maternal mortality also. So it is very important, very important, whether to in the fetal surveillance start doing Doppler in all the trimesters.
There any what are the practical and clinical situation where you use umbilical vein? Is the final stage. Umbilical vein is the final vessel to get abnormality. So that's it. So if there are any more questions, let me check. Okay. How to make gynec write Doppler in place of FWB only?
It's
Whether they ask for or not, do a Doppler. Whether they ask for or not, it's mandatory that you do a Doppler. CT brain is asked, it means you are going to report the calvarium. Is it fractured or not normal? It's similar to that. So Doppler is definite. Don't think Doppler difficult or the questions. All this comes because we think Doppler is a very difficult tool. It's not so. Once you start practicing, it just gives you so many fruits and it's so easy to do. Once you start doing it, your hands comes very easy.
So from my experience, I think once you start giving it to the gynecologist, once you start giving this information to gynecologists and they realize that it is of clinical importance and it is benefiting them in their inpatient care for them as well, they automatically start demanding it. So it has happened probably, all of us at our own places in our own cities, we are all practicing it. I have been doing Dopplers with my growth scans, and now I'm seeing a lot more gynecologists, them being aware of how the Doppler and growth are working together, in improving fetal care, in improving patient care. So yes, you just have to start offering it to them, make them realize that it's definitely useful. The demand is going to follow.
They'll definitely come back.
See, what is the purpose of fetal surveillance? We have to do the fetal surveillance properly. First, we have to date the pregnancy properly, then only we can do the growth scan. And with the growth scan, to see whether the fetus is at risk or mother is at risk, you have to do the Doppler. So, this is the complete examination, need everything, three things: dating the scan, see as a growth velocity, and do Doppler to identify the risk proportion. So, fetal surveillance means all the integration of three parts. Without it, you are not doing fetal surveillance, right?
Also look into all the previous reports.
Yes.
That's very important. Let's say you wanted to ask something.
No.
Okay. So
Abnormal CPR below 37 weeks, what is the recommendation for follow-up? If it is just abnormal CPR weekly and then deliver at 37 weeks, that is how it is going. That's the best question of the evening. How to be a participant and contribute in Samrakshan protocol. It's very simple. You visit the IRIA website. There is the Samrakshan program there. You can go there. There are forms available for first trimester, second trimester, third trimester outcome. You start gathering data. You need to train your staff into what parameters they need to take, how the MAP is taken, how to enter the details in the calculator, then you'll be on a roll. So it is not really difficult. You just need to go on the IRIA website and visit the Samrakshan module.
So
we can come.
There are no more questions.
Yes.
If there are no more questions, we'll wind up the session.
Yes.
We fill online forms or on paper. We fill online forms. The forms are filled online.
Over to Lalit sir for some closing comments.
Okay. On behalf of Samrakshan Society and IRIA, I am highly thankful to today's chief guest, Dr. Subhash Taylor sir, President IRIA, Rajasthan, and Secretary Dr. Jivraj Singh, and all the Dr. Neelam Jain, who has enlightened us on the AGA with FGR. Very nice talk. And I am thankful to our national lead Samrakshan, Dr. Bhavaran, and all the attendees. Because without you all, the Samrakshan program cannot reach to all these states. We want that Samrakshan should be adopted by all the radiologists, all the stakeholders, which is required for the reducing the perinatal statistics in our country, and it is very high in particular the central state like Rajasthan, Madhya Pradesh, Uttar Pradesh, Odisha, Bihar and Assam, where even the maternal mortality has increased. So as Dr. Subhash Taylor has promised us and Dr. Jivraj Singh ji, I am very thankful, and I will try to on behalf of the Samrakshan committee to work with you all and help in reducing the maternal mortality as well as the perinatal mortality statistics in Rajasthan as well. And very thankful to all the chief guests, starting from the 22nd May which was inaugurated by the AOSR President Dr. Evelyn Ho, and then Dr. Praveen Kumar, Professor Prem Kumar ji, Madam Shivam Mehra ji, Shivani Mehra ji, Punjab IRIA President, Kerala IRIA President, and all the chief guests from the Gujarat as well as Maharashtra. All the chief guests I thank on the behalf of the Samrakshan Committee and the IRIA Kerala who has arranged this program. I am highly thankful to the MedPiper who has arranged this for all of us, and thank you very much. Thank you everyone, and let us work together in the Samrakshan under the leadership of IRIA, ICRIA, and help our country in reducing the perinatal mortality as well as the morbidity. Thank you very